All right, well, thank you everybody for joining today. We're very happy to have Dr. Schmied with us. He's a cardiologist and sports exercise medicine physician based in Zurich. And he'll be presenting some cases today. He is Chief of Service at the University Heart Center in Zurich, and he's also doctor for the Swiss Women's National Ski Team, for an ice hockey team, so he's worked with plenty of different athletes, and we're very happy to have him here today.
Yeah, thank you very much, Isabella. I was really excited to get invited. As I wrote you, I would rather prefer to visit you in Cambridge, but I hope it's gonna work out next time. So I'd be pleased to talk to you again. So I'm happy to present some sports cardiology cases, but I might start with just a little introduction who you are dealing with today. So as Isabella said, I'm a chief of service and lecturer at the University Heart Center in Zurich. So I'm a cardiologist, but also a sports physician. And let's say like the hybrid of both is like the topic of sports cardiology. And there's quite a community, a global community in this, focusing on this topic. So it's really exciting, and I hope I can show you some of these exciting issues of the topic sports cardiology tonight. So this is my team, so quite a big team, a large team dealing with sports cardiology, but general cardiology as well. And of course, cardiac prevention in general. So we have also our cardiac rehab program, as you see here at the university. But a very nice thing is that I invented also, let's say, a satellite in the Swiss mountains. So it's nice to switch workplaces sometimes. So I like that a lot. Of course, we do a lot of teaching as well. So you see 2 courses in sports medicine and sports cardiology at the university, and the ETH in Zurich, where we do also a lot of practical stuff, as you see. And of course, there's also a lot of parties in the evenings after these events. So a lot of sports medicine and sports cardiology also in Zurich and Switzerland. And I'm excited that it's the same situation, particularly also in England, of course. So some impressions of my environment in Zurich. These are my contact data. I'm going to show this also after my talk, which will take approximately 40 to 50 minutes, if that's all right, but we can discuss at any time, of course. I can make a quick break after each case, but in case of any more, if you need any more information or publications and stuff, or slides, anything, I'd be happy to provide you also my PDFs if you like. So please contact me if I may help you or support you. Well, I think sports cardiology and cardiac issues, cardiac arrest in sports got another hype, let's say, this year or last year, better to say, during the European Championships of football and this tragic but lucky, in the end, lucky event of Christian Eriksen. I think you all got it at that time. And also for me as a sports cardiologist, let's say, it was really impressive. It was really a shock to see that live on TV and yeah, to see and hope that everything is going to be fine. But a lot of interesting issues there, which we can address also today. Another interesting fact actually was, and I don't know if you realize that just a day later, there was a player that suffered from such a tragic event already. So he played with an implanted defibrillator. So Daley Blind, one of the players of the Dutch national team, has already a situation that Christian Eriksen is dealing right now with it. So he started again to play in England. So Daley Blind is even on a national, international level with an ICD. So this was quite an exciting weekend for sports cardiologists, I have to say. So the aim and background of this talk is not just football, but of course, if I'm talking about sports cardiology and football to English students and physicians, I have to address that thing that at least it's a chance that football should come home at one point, and of course, football is a very important thing, if not the most important thing. It is maybe the second most important thing. But I think England and football, this is quite an important relation. And yeah, there's quite a debate where football has its real origin. So that might be China, but I'm rooting actually for England. And it is a fact that the first really structured rules of football have been developed at your university, at the University of Cambridge, which is quite a nice fact, I think, in this environment here. So, and also, I don't know if you realize that these current rules with 11 players and with a guard is originated in the dormitories of the students there. So there were different dorms playing against each others, and in every dorm were 11 students, and one of these students was the guard of the dorm. So the guardian also after this, the goalie, let's say, in the team later. So this is actually the background, which is quite funny and exciting, I think. But you might have seen that I'm a consultant for the FIFA for quite a long time. I think the FIFA has a lot of had a lot of bad press and a lot of bad news, but I really have to admit that for medical purposes, for sports medical purposes, and particularly also for sports cardiology purposes, they really did an amazing job. And it started many decades ago, when in 1994, the so-called FIFA Medical Assessment and Research Center has been established. And since that, we have really had a lot of exciting projects, not only in the issue of sports cardiology, of course, but particularly in sports medicine. I'm going to show you a link or quite a nice tool at the end of my talk where you might be interested in. But of course, there is also the bad side of the FIFA, and you're all aware of these scandals and stuff. So, but as I said, the medical part of it is really exciting. And we developed a lot of special projects, all named after the 11, according to the numbers of players in a team. So, for example, the famous 11 plus to prevent injuries, you might have heard about it. So I don't want to talk a bit about it today, but of course, today I'm going to talk about the prevention of sudden cardiac death in football, in sports. So the 11 steps to prevent sudden cardiac death is another project, 11 rules to prevent doping, and 11 for health to prevent various diseases. So quite some nice programs the FIFA developed, and we really can look back to a lot of publications dealing with football and sports medicine and also sports cardiology. Well, regarding sports cardiology, there was, let's say, like an impact issue dates, June 2003, there was this tragic death. You might be aware of Marc Schmied. It was a Cameroonian national player who died in front of the TV of millions of spectators at the Confed Cup. And if we compare what happened there some 20 years ago and last summer during the European Championships, some things changed, and that was really important. And this was kind of the let's say this tragic event really prompted some developments within the FIFA, which were really important, not only for football, but also for the whole sports medicine and sports community. Actually, in London or in England, there are very exciting scientific teams. And I think one of my favorite publications, recent publications coming out of Sanjay Sharma's group in London, was a database which was dealing with outcomes in cardiac screening. I'm going to talk about screening too. So we have really nice data, particularly also from England, which I want to deal with. And we can, according to this publication, we can estimate an incidence of sudden cardiac death in sports or exercise-related sudden cardiac death of approximately 7 deaths per 100,000 athletes per year. So this comes out of this really exciting recent publication here. But there are some risk factors for sudden cardiac death in sports, and these are well defined, as you might see here. And particularly with the FIFA, as we are a global association with all these risk factors harbored in all our players, males or females, we have to deal with these risk factors. So these are the risk factors for sudden cardiac death in sports. It is at one point the competitive part of sports, so the high intensity also, according to the type of sport or exercise. It's more the older athletes or male athletes that harbor an increased risk. There are some ethnicities, interestingly enough, for example, the Black Afro-Caribbean ethnicity, which harbors an increased risk for sudden cardiac death. There is the low daily life or baseline activity, which is not only a problem, I guess, in Switzerland, but also in Britain, where in Switzerland, we have to deal with approximately 40% of the population, which is not exercising enough during the daily life. And there's, let's say, weekend warriors, they go really hard on the weekends or on a sports event or a competition. And then it's we have to deal with a dramatically increased risk. And last but not least, of course, there is also a huge gray zone of doping and drug use, not only in professional players. So the question is often posed: are there some kind of sports or some sports disciplines which harbor a particularly increased risk? And I don't know, and I'm not sure if we can really accurately answer to that question. I think I have, just as an example, I have two studies brought with me that might answer the question. At least it does for me, or they do for me. So first, at the very left of the slide, you see the famous race study. So a study out of America, out of Harvard, from good friends of mine, which have focused on millions of marathon runners in the USA. And the good news was that there was really an unexpectedly low incidence rate of sudden cardiac death. But what was really impressive and shocking, let's say, if you die during a race, during a marathon race, it's almost exclusively during the last 10 kilometers. So this is really an important fact for me. So once physical and psychological stress or exhaustion comes together, it gets really dangerous. So I think this answers the question regarding risk independently from the kind of sport. So every sport can harbor this situation where you deal with a lot of stress physically and psychologically. And another interesting study highlighting also the role of emotional stress, of competition. This is the one on the right. It was not made on athletes, but it's dealing with sports. Maybe you're aware of it. So quite interesting and exciting study. You see the cardiovascular event rates in 3 different years, and you see these peaks in 2006. So this was quite a long time ago, but you probably might know what happened during these times in the greater Munich or Germany area. It was the FIFA World Cup. And these peaks were exactly the game days of the German team. So it's really interesting that just due to the fact that the national team, the local team is playing, and they won until the semifinals. So they did very well. So, but despite the fact how they played, just the fact that they played, the excitement and the hope that they will win, that the summer fairy tale will continue, just led to this massive increase of heart attacks during these game days. And even more interesting, that you see that kind of Gauss distribution. You see that the majority of myocardial infarctions happen just at the beginning of the game. Not in the 90th minutes where Germany is back 1 goal or something, just at the beginning. The referee blows the whistle and the heart attack occurs just due to the fact that this excitement is so huge. So that answers the question for me too. So again, emotional stress or emotional psychological exhaustion together combined with physical stress, this really increases the risk for sudden cardiac arrest or arrhythmia massively. And another important fact for me too, and you will see some competitive top athletes in my cases, but also some hobby athletes. It's not just an issue of the very top, or the top of the pyramid, the best of all, or most skilled athletes overall. These impressive data out of France show that by far the most cases of sudden cardiac death occur in so-called leisure or hobby athletes. You see in red, you see the competitive athletes, but in blue, you see these so-called hobby athletes in their 40s or 50s. More than 90% of these fatal events occurred during hobby sports, recreational sports. Only 6% in the so-called young competitive athlete community. So this is also an important fact. We're not dealing, not only in football, but generally in sports medicine, we are not dealing only with young competitive athletes. For example, it's an interesting a subgroup of football players, let's say, or athletes involved in the games are the referees. And we regularly do screenings in these, and you see that there are a lot of internal medicine diseases, cardiovascular risk factors, these referees, these top athletes, let's say, harbor. So we really have to deal also with so-called older athletes. In this case, some important, at least for my generation, athlete was Iker Casillas, so the long-term Spanish national goalie who suffered from myocardial infarction in his 40s. So that's not really an issue in sports cardiology. So this is quite a common finding in these athletes. Football is also a global sport, and even more in England, you have these multicultural athletes, and particularly also, this is a nice study out of the London group from Sanjay Sharma, we have to deal with different ethnias, and we know very well the fact that the so-called Black or Afro-Caribbean athlete's heart has a lot of gray zones together with serious conditions like the hypertrophic cardiomyopathy, like right ventricular cardiopathy, or the left ventricular non-compaction cardiomyopathy. So it's quite a challenge to differentiate between physiologic athletes' heart changes and really severe or pathologic conditions. So this is also quite a challenge, and even that was quite interesting in some of my projects on the African continent. It even differs regarding the different African regions. So it's not only the outside, the athleticism of these athletes when you see them coming at your office. So the Western African athletes that are more muscular, more athletic, they have also more thickened heart walls. So it's quite interesting that these athletes also differ not only from their athleticism, but also from their physiologic heart conditions. So the development of the athlete's heart quite differs even on the African continent. So this is quite an interesting fact. So a lot of challenges, but a lot of exciting topics. So I want to close my short excursus regarding FIFA with the 11 steps to prevent sudden cardiac death in football. So we developed specific FIFA pre-competition medical assessment, which you see here. So various screening topics we addressed. So I think this was really a nice invention. So I will lose some words at the end of my talk regarding the FIFA football medicine program. But I want to start now with the first case. It's not a football player. It's actually quite a young female athlete in a sport that is really popular in Switzerland and in the Scandinavian countries. It's called floorball. Isabella might know it. So it's quite a popular sport. A lot of young kids are playing this in Switzerland. So it's kind of a hockey you play, but indoors. So there was a young player that recently complained about some unspecific dizziness or let's see, early exhaustion at some point, but nobody really cared about it. Even she didn't care really about it. She wasn't bothered about it. But there was that Saturday afternoon game day when she suddenly faints on the field. She recovered quickly and went to her coach, but she was still kind of shaky and dizzy. So the coach brought her to our hospital. And I was on duty on that day, I remember well. So on the emergency ward, she presented with quite a hypotensive blood pressure. She had a weak pulse wave and quite a high heart rate of approximately 150. She was clear, but she was really decelerated, so kind of dizzy. So what would you suggest as a first test? Of course, I'm a cardiologist, and you would also probably provide an ECG. And this was her ECG. So just have a quick look on it. So it looks quite scary, I have to say too. So what is your first impression? So differential diagnosis, just some quotes. What do you think? No idea, but it's pathologic. So it's really tachycardic, so approximately 140, 150. There are broad complexes here, so no slim QRS complexes which you are aware of. So this is, at the first glance, it's a ventricular tachycardia. So she was hemodynamically unstable, so we did an electroconversion, and this was the ECG just after the electroconversion. So maybe some of you or one of you will speak up about this condition here. What do you think, just as a first impression? It's a sinus rhythm now. She's quite slow. She's well trained. But what do you think about the T waves? You see here T wave inversions in V2, V3, also slightly here on V4. These are really pathologic, and there are some other spikes here which you might see, but maybe one of you can already set a diagnosis on this. So this is really specific. So if you have this condition, so first the ventricular tachycardia with that particular vector, electrical vector, and after this really pathognomonic ECG, it's even enough to pose a diagnosis. Has somebody an idea? So maybe I can guide you through this. You see these negative T waves over here on the right precordial lead. So it might be something of the right heart, and it was something of the right heart. You see here the original echocardiography of the girl. This is the right ventricle. You see the hand over here. You see it moving on the screen. Okay, so this is the right ventricle. It's really massively enlarged. This is the normal condition on a short axis view. And this is the four-chamber view. You see that the left ventricle is there really small, and the right ventricle is massively enlarged. And with this condition, we can really set the diagnosis of right ventricular cardiopathy. It's called particularly ARVC, so arrhythmogenic right ventricular cardiopathy, a highly dangerous situation, and particularly during sports. This is really a massively increased risk for sudden cardiac arrest and death. So unfortunately, this athlete got also, or had to got an ICD. So this was really a dramatic condition. Fortunately, she survived, but after this, of course, she had to live or to deal with this ICD. So generally, there are some issues regarding differential diagnosis. I mentioned that regarding different ethnias, but particularly also regarding the right ventricle. We know that this is kind of an Achilles heel of the athlete's heart. The muscle layer is quite thin over there, so this is really prone to enlargement and also kind of a fatigue. So you see in this slide here, it's quite a challenge to differentiate. In this particular case, it was really clear that this is a severe condition. But anyway, you have to be aware of the fact that we can find that physiologically this enlargement and also kind of a fatigue of the right ventricle, which is regressive. So after a break, you can really develop or have a remodeling of these dilation of the right ventricle. But this is, as I said, kind of an Achilles heel. And even in very early descriptions of the so-called athlete's heart, these professors, where they didn't have the possibilities regarding imaging, they already showed that there is kind of a right heart affection in these skilled athletes. So this might be quite an issue to differentiate between a pathologic finding and a physiologic finding. Once you have a diagnosis of this arrhythmogenic right ventricular cardiopathy, it's really, I would say, one of the only conditions where you have to deal with a situation or with the fact that you cannot participate anymore in any competitive sports due to the fact that it's really highly arrhythmogenic, and even more, only if you have the situation of a genetically positive situation. So if you don't have this enlarged right ventricular condition, you can even develop the disease by continuing doing sports. So this is really a bad situation, and I would say likely the only situation in cardiology and sports cardiology where you really don't have to, or you cannot recommend to continue sports. So this was the fact with this girl. An ECG during a symptomatic phase is crucial. So it was really diagnostic, I can say, in this situation. But once you have diagnosed this ARVC, then it's quite a dramatic situation for professionals, but also for hobby athletes, because they have to deal with the fact that they have to stop doing competitive sports. So are there any questions for that first case so far? Nothing. So I would just continue. You can interrupt me at any point, of course. So now
I had a quick question about that.
That's a question.
So you were speaking about the AC and how athletes are advised not to do competitive exercise.
Yeah.
But are they still recommended to do some exercise? And how do they know whereabouts the limit is?
Yeah, this is a good question. I have to really admit that there aren't very good recommendations. So I can go back maybe. Not to participate in competitive sports is quite a hazy recommendation. So what we really recommend is not to do intensive or moderate sports anymore. So we are sticking with really mild intensities. But to be honest, there are no clear recommendations. So we're doing a study right now in Zurich where we are observing ICD carriers. So to be on the safe side with these guys and patients with strength training. So I'm really positive regarding this, so that they can do some strength training. But I really have to admit, it's really a bad, severe condition. And it's not all about arrhythmia induction. It's also about a worsening of the disease itself. So we know that once you have it, just the genotype positive condition, you can really worsen the disease by any sport so far, but we are working on it. So I'm really positive regarding strength training at a very low intensity actually, but this is really a bad condition. Yeah. So I would continue with the next case. Now we have a football player, but really let's say a leisure player, a 24 years old male, originally from Africa, immigrated Cameroonian player who does also some kind of strength sports, and he came back recently or recurrently with some unspecific symptoms like decreased physical capacity, some dizziness, some nothing really specific. And there was the label of a so-called white coat hypertension. So every time he deals with a doctor or a pharmacist or somebody, he has increased blood pressure. But once he measures at home, he just admits at least he has normal blood pressure findings. So this was actually his ECG before he visited our place for the first time. So that looked quite fine. But the first time he visited our center, you see these changes over here. So it's again an issue with these negative inverted T waves over here. So remember well, it's a strength athlete, strength training athlete too. It's from Black African origin. So you might have heard that they have some different ECGs, physiologic ECGs. But again, we have these very high, I have to admit, very high blood pressure values at rest. So what do you think? I mentioned these particular athletic ECG conditions, and I don't know if you are aware of ECG or very well aware of ECG interpretation, particularly in athletes. So it's quite a challenge due to the fact that they have these a lot of physiologic athlete hearts changes, and of course these changes, structural changes, also cause some ECG changes, but these are physiologic and normal findings, and that would really prompt these so-called international or Seattle criteria, which we developed on a global expert base, which I really like. So we really defined these normal ECG findings, which do not ask for further examinations. But there are also, of course, these red flags, as we saw with the young floorball player before, but also in this guy here with these negative T waves, these T wave inversions. But we also know that there are some physiologic conditions, also T wave inversions in Black athletes. So this is quite a challenge, or this was a challenge actually. We know, at least also by a lot of English or British data coming out of your multicultural population, that there is a so-called Afro-Caribbean early repolarization or T-wave inversion pattern, which you see here. You see these T-wave inversions in the precordial, right precordial leads. So similarly to the girl I showed you first, but they are together with these ST elevation here. So you see this typical Afro-Caribbean early repolarization pattern, which is not the fact in our athlete actually. So we had the T-wave inversions here and on the lateral leads V5 and V6. So this is not a physiologic condition in an athlete from African condition, I have to say. So it was more this condition over here, and this is pathologic. So we had to prompt further examination. So as a conclusion, there are some unsuspicious T-wave inversions, particularly in the anterior leads, but once you have a lateral or infralateral T-wave inversion, this always prompts further examination. So we did that, of course, and we did an echocardiography. And I don't know how familiar you are with these echocardiography findings here, so I'm going to show you through it. This is a so-called parasternal longitudinal cut, which you see here. You see the left ventricle, you see the right ventricle over here. This is the mitral valve, and this is the aortic valve. This is an apical view with the left ventricle here and the right ventricle over here. And this is, again, as we saw before, a short axis view, and you see the left ventricle over here. So not even if you're not an expert, it doesn't matter. So what do you think? What are your thoughts about these echo slides, these findings, particularly of the left ventricle? So what do you think? In the meantime, I check the chat. There are some questions probably also in the chat. Okay, yeah, Hockham, yes, it's very good. So a hypertrophic left ventricle, so I think you all agree on that. Maybe we can go back to make that running again. Yeah, it's a hypertrophic left ventricle, totally agree. What is this? What do you think about this? This layer over here, just around the whole heart, let's say, also here around the atria. So maybe you prefer to write in the chat also, I can check that too. But this is something yeah, difficult or something different too. This is pericardial effusion. So this is also a pathologic finding. So what we find here is pericardial effusion together with a concentric hypertrophic left ventricle. So this is nothing physiologic anymore. So the question, is there a physiologic athletes or is there real cardiomyopathy, could be answered with a clear no or towards cardiomyopathy. So the physiologic athlete's heart is more like an eccentric development, the concentric hypertrophy, so a pronounced hypertrophy of the walls, which you saw just in our athlete, is sometimes due to doping. So we have a lot of cases in athletes taking anabolics, but it's also the case in hypertension, for example. Sometimes it can be physiologic in Black Afro-Caribbean athletes, but in this case, really it was too much. So this was really a pathologic finding. So what we did, and this was quite exciting, the patient actually didn't have HOCM or HCM. He had hypertensive cardiopathy. So you remember the diagnosis of so-called white coat hypertension, which is always suspicious, I have to say. So we did a 24-hour blood pressure monitoring, and you see that he had throughout 24 hours, he had elevated blood pressures. And this was the diagnosis in that patient. And the pericardial effusion was due to renal insufficiency, so severe renal damage due to hypertension over years or even decades. We don't know, but we could treat that patient pretty well. And we have some nice data, not only in athletes actually, that we can treat hypertensive cardiopathy quite nicely with any kind of antihypertensive drug. So you know probably the ACDC algorithm. So RAS inhibitors, calcium antagonists, or diuretics, either of them does work. And also in our athlete here, he really showed a massive decrease of this hypertrophy, and also the kidney resolved. So this was quite a nice case also to help the athletes, the athlete that was quite dramatically ill at that point, I have to say. So this was a kind of a nice case too. So any questions regarding this hypertensive cardiopathy? There are no questions so far or remarks. I would just move on. I think I could skip these slides. They're dealing with exercise hypertension. Maybe just this slide here is quite interesting. How about this white coat hypertension? As I mentioned, this is always a suspicious diagnosis. Once you read this, you really have to question it. I mean, it's quite frequent. Up to 30% of these patients show these white coat hypertensive situation, even more once they have a diagnosis of hypertension and they take drugs. But you always have to question it, and you always have to provide like 24-hour blood pressure monitoring, or they have to measure themselves at home. So always question this diagnosis once you read it. So any questions to this second case or remarks? I think it was quite a nice case because we could really treat it sufficiently. So if not, I can just move on with another football player, which we were dealing with in our at our hospital, at our consultations. This was a really prospective player, 21 years old, so really a football talent, surrounded by many of the top international clubs. But unfortunately, he got diagnosed so-called left ventricular non-compaction cardiomyopathy. Just show you a slide about this when you're not, if you're not aware of the disease specifically. But this is also quite a relevant cardiomyopathy. So he was diagnosed with this at another hospital, a private hospital in Zurich. So he came to my office, to my consultation by self-admission for a second opinion, because he was really sad about the situation. So they told him he couldn't follow his prospective career he planned to do due to this left ventricular cardiomyopathy. So just some slides about the condition. The left ventricular non-compaction cardiomyopathy is, as the name says, is a non-compaction of 2 layers of the myocardium during the process of compaction during the fetal development. Once these patients, these athletes got diagnosed, you see these typical findings in the echo, where you have this large so-called non-compacted layer, and as a consequence, mostly they have also heart failure with reduced pump function. So there are different diagnostic criteria, which I showed you here. So all of these harbor this layer, this non-compacted layer, which you can also see in the MRI. So this patient had the condition. I show you the original echo runs over here. You see again these short axis views over here with this this trabeculated non-compaction layer over here. You see that? And also in the 4-chamber view, you see here on the left side, this non-compaction layer over here. So I couldn't give the athlete better news, I have to say. So this was really a finding I could confirm. But what I advised, and this is my take-home message in this case, I mean, he was disqualified anyway, so he had to pause anyway. So what I recommended to the athlete, well, once you have to stop doing competitive sports, why don't you come back in 3 or 6 months and we repeat the echocardiography? So without doing any training, so it was so-called deconditioned, and he came back to my office after a couple of months, so 3 months actually, and he of course presented still with this non-compacted layer. But interestingly enough, all 4 cavity dimensions were in a normal range. He had a normal function of both ventricles, and he was still asymptomatic. He had normal ECG monitoring, also outpatient, and he had a totally unsuspicious exercise test. So we were dealing with a totally asymptomatic, top fit athlete with just let's say, an echocardiography situation and a presentation of a so-called non-compaction layer. So what we were doing with this athlete was quite exemplary. And I show you here the current European recommendations regarding non-compaction cardiomyopathy. So quite a severe condition. And you see here, it's a class 2A level of B evidence recommendation, but still we recommend, if the patient is asymptomatic, if he show a normal heart function, which he showed, and no suspicious finding during exercise or outpatient ECG testing, we recommend no restriction from all competitive sports. And what we did with this, let's say, deconditioning of the patient, of the athlete, due to his disqualification, was we showed that these changes due to the athlete's heart really resolved, and it just has this non-compaction presentation, but with a totally normal function. So I could really recommend to continue the career. And I have to admit, the case is from, I don't know, 6 or 7 years ago. So the player now plays in Germany and in the first league, in the professional league, and has no symptoms at all. We make a checkup every year. So of course, the non-compaction presentation persists, but still the function of the heart is normal, no arrhythmia, no symptoms. So this is really an exemplary case where we could really, due to the fact that it's a normal heart function without any arrhythmia, pro-arrhythmia, we could really recommend to follow up the career. So this was really also kind of an impressive recommendation. This non-compaction pattern is quite frequent, again, in an Afro-Caribbean population. And we did some study in a, let's say, relatively homogeneous ethnic population in the country of Gabon a couple of years ago. And we could show that according or depending on which echocardiography criteria you propose, up to 60 or 70% of these, let's say, healthy athletes, they appear with this non-compaction left ventricle. So it's quite, it can be also a physiologic finding. I mean, this was not an Afro-Caribbean player, but still we have to be aware of, we have to be cautious with this preliminary disqualifications in these young players. So it's really a shared decision-making and a specific recommendation. And I think this was quite an exciting case, let's say. So detraining normally is not feasible. So you cannot provide or recommend an athlete, a top athlete, a professional athlete, to stop doing sports for 3 or 6 months. But once he has to stop due to disqualification or an injury or something like that, I mean, you really can do repetitive echocardiographies, and this provides some really nice information too. So are there any questions regarding this case? I don't see any questions also in the chat. If not, Isabella, how many more time do we have? So it's 7:20. I can stop here, or I can present another case as you like. I don't know what your schedule is for tonight.
Yeah, until 5:30 we've scheduled the call.
Perfect, so great. So I would just continue with another case. Another ECG case. So what's your opinion on this? This is an 18-year-old female volleyball player. She fainted actually after practice. She came to my office quite as an emergency too. So what do you think about this ECG here? You can also make some suggestions in the chat, of course. Otherwise, due to the time, progress time, I just guide you through this. You see a sinus rhythm, quite tachycardic, so quite a high heart rate. But what is really suspicious are these broadened QRS complexes. So this is a complete right bundle branch block. This is quite suspicious in this situation. So what do you think? What is your best or first guess? The player fainted after practice. Does that fit with pulmonary embolism, maybe tachycardic atrial fibrillation, a STEMI, so myocardial infarction, or just the right bundle branch blocks with yeah, that symptomatic presentation? So what is your first guess? There is one suggestion in the chat. Yeah, it's a right bundle branch block, but does that explain it, the situation? Does it just the right bundle branch block explain the fainting of it? So I might just continue and show you the solution of the case. She showed pulmonary embolism. Of course, we couldn't diagnose that just based on the ECG, of course, but it's a typical presentation of pulmonary embolism, the tachycardia, the signs of the right heart suffering, let's say, the right bundle branch block, other signs of right heart failure, let's say, and the typical S1Q3 type. I can maybe go back again. So you see that S1Q3 type here. You see the typical tachycardia and also the signs of the right heart failure with the right bundle branch block. We were completely right, of course. But we, of course, provided other techniques with the echocardiography. You see here quite a specific sign, the so-called McConnell sign. So a severe right heart failure. You see that the free wall here doesn't move at all, but just the apex of the right ventricle does move, still moving. So McConnell sign here. And last but not least, of course, we provided pulmonary angiography, and we could confirm the diagnosis of pulmonary embolism. So this was quite an interesting case. And just to add something more to it, I didn't mention the other findings which we did. So this was a finding which I couldn't really interpret at the first place. So that wasn't her toes actually, but they looked actually quite the same. So do you have any association with that? So she had pulmonary embolism, totally healthy young woman, let's say, who suffered from that condition, but she had also this appearance of the skin of the toes actually. So I learned actually just a couple of weeks later that we can name this situation the COVID toe or the COVID foot. So she suffered from a coronavirus infection, and you all are aware of that, of course, after 2 years of the pandemic. But we all know that COVID is not just a disease of the lungs, but also of the endothelium. So that young volleyball player suffered from endothelitis, thrombosis, and pulmonary embolism, and the toes were also another affection. Let's say an embolic event of these thrombosis, of this endothelitis she suffered from. So this was quite interesting. Looking back, of course, we now know that we are dealing with a lot of cases also in long COVID, like post-COVID right now. And we can break that down on endothelitis. So we know that the SARS-CoV-2 virus is also causing endothelitis, and this causes a lot of problems. Also, I saw a lot of LEs, a lot of embolism, lung embolism in athletes. These are some interesting, impressive images, electronic microscope of the vascular injury caused by COVID-19. So quite impressive case too. Okay, so I have 4 more minutes. So I would suggest to jump over the next case, which was a myocardial infarction, and just close with one last case, which I like a lot, and which goes a little bit also into the situation I started with. Football players with ICDs, football players with sudden cardiac arrest on the field. And this is another player, very interesting case I want to close with the whole lecture. This is Rafael Duamena, a player that was transferred actually a couple of years ago from Austria, so a minor league from Austria to Switzerland. And then an English Premier League club wanted to trade him to the Premier League. But once they had that medical check over there, they refused him because they did an MRI and they said, you know what, the player isn't able to play anymore. And this was a huge issue in Switzerland because everybody was excited, you know, that young, talented player from Austria bought for just a couple of thousand Swiss francs, and then a Premier League club bought him for a couple of millions of pounds, but they refused. And that was the situation. That was also the moment where I got involved. So he came to to the hospital because everybody was asking, wait a minute, he's playing in Austria and Switzerland, but the English doctors, they won't let him play. So what's the situation? So this was the situation. This is his MRI. And you see this fibrosis over here. So this huge scarring over spreading all over the left ventricle. And the cause of this was a myocarditis. So he suffered from myocarditis a couple of years ago. We have these ECGs from Austria. So he never underwent MRI before, but he underwent various ECGs. And you see here that he had a pathologic ECG some 8 or 10 years ago, a very long time before he was transferred to Switzerland. So I admit that he suffered from the acute myocarditis, let's say 10, 14, maybe 15 years ago. And then he came back to Switzerland. So the English doctors refused him. So this is just a chronic state of a myocarditis. So what we did, the player wanted to continue to play at any purpose. So we did implant a loop recorder, so-called Reveal, and we let him play. He got his transfer to Spain, actually. And 3 years later, they contacted me again. So we lost a little bit the contact. But 3 years later, so let's conclude 15, maybe 18 years after the primary diagnosis of acute myocarditis, he suffered from this. This is the monitoring, the ECG monitoring. So he suffered from acute ventricular tachycardia. He fainted on the ground. So this was really impressive. And it showed me that once you suffer from myocarditis, and after resolution of the acute situation, you come out of it with a scarring, with a fibrosis, it's really a lifelong risk to suffer from arrhythmia, from severe arrhythmia. And if I go back to this guy, Daley Blind, he suffered from exactly the same situation. So he suffered again, like Rafael Duamena, from these ventricular tachycardias. He got an ICD, he plays on a very high level. Unfortunately, Rafael Duamena, who got an ICD-2, of course, he still is looking for a club to play for, because everybody, of course, is anxious regarding this condition. So this is quite an impressive case, and we have a lot of myocarditis situation, not only related to COVID, but to any kind of respiratory virus, of course. So this is really a challenging situation. Once you have a CMR, an MRI diagnosis, you have to follow them up really closely. And if they come out after sports restriction for at least 3 to 6 months with a scarring, with a fibrosis, you really have to assess them accurately to estimate their arrhythmogenic risk. So this was quite impressive, let's say. So I want to close with this. If we have time, another minute, I just show you that movie of the FIFA Diploma of football medicine. So if you are interested in it, go to the link, check it out. It's not just about sports cardiology, of course, it's about any topic of sports medicine. What I like, I really like that project. So if you're interested in it, just check it, and maybe you can go through these courses here. 42 courses overall, so really a nice invention also of the Football for Health, or F-MARC initiative. So thank you very much, Isabella. Thank you all for participating, for inviting me. I hope I could provide you with some nice cases, interesting cases. And as I said, if you have any more questions or requests for data, for papers, or slides, just contact me. It would be a pleasure to support you. Thank you very much.
Thank you so much. Does anybody have any other questions or anything else they'd like to ask before we conclude? No, everybody happy?
I hope so. I hope so. Thank you very much, Isabella, and everybody, and good luck. And I hope we see us in person very soon.
Yeah,
thank you.
Hopefully we can arrange another event in person.
Thank you.
Would be great. Thank you very much for your time and for the talk. It was really great.
Bye-bye. Have a nice evening.
Thank you.
Thank you.
Thanks. Bye.